Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Open, outspoken, it's ophthalmology off the grid, an honest look at controversial topics in the field. I'm Blake Williamson.
Welcome to another episode of Ophthalmology Off the Grid. I'm your host, Dr. Blake Williamson, and I'm super pumped for bringing up this third installment of this sort of ASC series that we've done. So if you're just kind of tuning into this, I want you to go back and listen to the first two recordings, literally the past two episodes of Off the Grid. The first one, we're talking with Michael Patterson, is explaining to the audience and to the listeners, what's the point of an ambulatory surgery center and why might you want to own one? A lot of our younger colleagues don't know about ownership in an ASC and what's possible and why that might be attractive. The second episode with Taylor Strange was all about how do you build one, and once you decide that you want one, how do you go about getting a loan from the bank and setting up consultants to build one, and what was that process like, and how can you make it successful as a young ophthalmologist? And then in this third and final installment, I thought that I'd call on the help of a mentor and who's also become a friend, and that's Jeff Whitman in Dallas, Texas, who has been sort of close to me throughout my early career and helped out quite a bit. And the reason I wanted to reach out to him is because he's a legacy owner of a very busy practice in ASC in Dallas, and has sort of done things the right way of selling shares to younger, talented ophthalmologists who are entrepreneurial and want to have some ownership, not only in the practice, but the ASC. So we have Jeff on today. And then the other point of view I wanted to get was from a colleague and acquaintance I'm just now getting to meet, Dr. Jorawer Singh. And what's great about JR is we had a very thoughtful discussion on a different message board about some of the challenges as young ophthalmologists trying to buy into ASCs. As he'll speak to today on the podcast, it's not that easy sometimes. A lot of these people who are owning significant shares in ASCs just aren't selling them. In some cases, they're not even operating. And so that's a challenge. So I want to kind of get his perspective and maybe see why Dr. Whitman decided to do things differently, what I believe is the right way. And then helping us out from the consultant side, lastly, is the great John Blanck and Bill Rabourn, who I've come to know through OOS, a wonderful organization that all of you in the surgery center space should consider being a part of, just to kind of give us their perspective on why might these older ophthalmologists who own these shares not sell? What can we do for them to consider selling more shares? What does it mean for the future of ophthalmology if they don't? Will PE just continue to gobble up all of the opportunity? Will more young doctors go to OBS, office-based surgery, because they can't get access? So that's kind of the arc of today's episode, and we'll run a little bit longer because we have multiple voices that we want to hear from. But maybe Jeff, if you don't mind, I'll start with you, and if you can kind of just give us your perspective. And just tell us how your surgery center is set up, because you're no longer the sole owner of your surgery center. You've had very talented colleagues come in and work and now are partners with you. Kind of walk us through why you decided to do that, because you could have just sold out to PE and walked away with a big bag of money. Walk us through that.
Well, that's right. I mean, we have a lot of decisions in this world, particularly in medicine. And I think sometimes it just comes down to the right way and the wrong way. And the right way is not always the most, how much money I can put in my wallet before I leave. And, how do you bring talented people in? Well, I think one of the ways, there are other ways, but one of the ways you bring talented people in is be able to offer them some type of partnership track. We've had, for years and years, we've had our doctors buy into the location. If there's real estate to buy into, they could do that too, but otherwise to the practice itself. But by into the location, they spent the majority of their time doing their clinical work. Then, as far as the ASC goes, for also a number of years, probably going back as far as since we built our new surgery center, so that's been probably about 6 years now, that we now have 5 or 6 of our partner docs have bought into the surgery center. By the way, there are some creative, you have to work with your tax planner and all, but there are some creative ways to get ancillary personnel, maybe an administration, optometrist, to buy into some type of partnership that's invested in the ASC so they can have a piece of the pie too. And the question then is why? Well, the why is loyalty. In other words, I want to stay here. I want to be here. I want to grow my family here because I have a future here. And part of that future here is I'm a partner in something that's going to pay out more money as time goes on. So the busier our surgery center is, the better everybody does. I do better because I have partner physicians that basically we're getting to the point where we don't have more OR time. Great, we have 4 ORs and we're busy, busy, busy. That may mean that we all invest in building another peripheral ASC somewhere, very profitable. The other thing is PE is a real thing here. It's a real investment opportunity. But why should I be the only one to get the advantage of that? I'd love for partner docs that are in their 40s and 50s to say, hey, now I don't have to worry about my kids' education. I can focus more on doing other things. By the way, there always is a danger with too good an investment is that somebody that's younger than I may decide to retire early. I hope that never happens. But again, it's all that incentive to stay with you, work with you, and increase your productivity. And you make them a partner, you're a good, honest person, you're doing the right thing. No, you could make more money holding on to everything, but I think you're going to go through more physicians that way. You're not going to have as stable administration. You're not going to have as stable clinical staff because they see this, revolving door of doctors. You need to step back and think, do I need all of this? I need maybe 51% of it, and let's start selling the rest to my partners. Once we have everybody's, they usually have a 2 to 3 year stability check to see how they're doing and increasing, and they're increasing their surgical load, et cetera, before we let them buy in. But I think you need to have a plan in mind when you bring somebody in and say, is this person within, and you'll know within a year or two, partnership potential and can add to the volume in my ASC, and it's worth making that sacrifice. But by the way, the sacrifices, they all have to still buy in. They're not going to buy in at PE rates, but they're all going to have to still buy in. So they have skin in the game.
Yeah. So John, why don't you follow up with that? And then Bill, I want to hear from you. Is that perspective, because it's so refreshing to hear that. And that's how we do it too at Williamson Eye Center. Is there a lot of that going around in the country, or do you get the sense that the majority of shareholders are just hanging on to their shares as much as they can? Is it equitable? Is it kind of a 50-50 thing where there's plenty of people doing it the traditional way, allowing young people to buy in, or is the majority of people just kind of hanging on for dear life? And maybe just kind of talk about the way Jeff's doing it and we're doing it, and if that is what you'd recommend. If our goal is to, still have, ownership of our practices and surgery centers going forward, and not all be a part of a large conglomerate.
Thanks, Blake, and thanks, Jeff. And yeah, I would say that more people are doing it, as Jeff says, it the right way than the wrong way. And that's good. And I worked as a healthcare consultant, and as when I was with senior vice president with Surgery Partners, I syndicated probably 50 different physicians. So sold them shares of our surgery centers, redeemed probably 20 physicians as they were, retiring, fully transitioned surgery centers from the founders to basically to the next generation. So we were very successful doing that. But you do have to have physicians that get it, like Jeff does, and like you, Blake, because you can look at it and say, well, I can make more money if I own 100% of it. You can, but if you bring others in. You strengthen the center. You make it more attractive to PE, ASC management companies, or other potential buyers. But for the most part, you're strengthening the center, and I think that's the critical thing. You're going to increase the bottom line, the top line, distributions, bigger pie. You may have a smaller share of that bigger pie, but it's going to be accretive, and you're going to make ultimately more money. All surgeons with the same common purpose, and being more efficient, best patient care, control cost, all those kind of things happen. And I think from the seller's perspective, you basically are diversify your risk. You're gonna, personal financial position, everything's tied up into your practice, your surgery center, and your building. Well, guess what? If something happens to you, and you can't operate, that goes away quickly. So it helps strengthen their portfolio, diversification, decreasing risk, and that's a big part of it. Just increasing their liquidity, and in a way that ultimately probably makes them more money, increases the value of their investment.
Bill, what are your thoughts here?
Yeah, thanks. Thanks for asking. I want to throw out a couple of things, because I agree with what Dr. Whitman was talking about, and also John. The one thing that I like to see is, especially for young ophthalmologists, and I think a lot of people are doing, to go back to John's comment, I think a lot of people are doing it the right way. And my hat's off to you, Blake and Jeff, for doing it the right way. But I think it's a great tool for recruiting. Right now, it's hard to recruit good ophthalmologists to practices. And I see this as a real opportunity to recruit doctors, good quality doctors, to your practice. Again, you're giving them the opportunity to, as Dr. Whitman mentioned, you're going to look at them for a year or two, make sure that they're good material. But you're going to say to them, at least I recommend that the young doctor, have an agreement that says, yeah, I have an opportunity to buy into the practice, then into the ASC, then maybe into the real estate. So that, again, to John's earlier point, you're growing that pie. And I'd rather have my piece of the pie, a smaller piece of the pie, with a pie being much larger. And I think the only way you're going to do that, because, let's face it, we're in the business of time. There's only so many hours in the day. So you're only going to be able to see so many patients and do so much surgery. Well, to me, there's always, not always, but a lot of times there's capacity in surgery centers. And if I can get young partners to come in and join the practice and do surgery in the surgery center, that pie is going to grow. And so as a result of that, as for all the things John just mentioned, better stability, more revenue, but also, let's remember, we are in the patient care business. So we're better able to serve the patients in our community, in my opinion, in an environment that is safe and secure, and in many cases, a better environment to operate in than other places, maybe in your community. So you're really providing a great service to the patients in the community.
JR, I'm going to bring you in here. So Dr. Singh and I, again, had a wonderful back and forth about this, because this sounds pretty good. And it sounds like, we're hearing from John and Bill that a lot of people are doing it the right way. But in your experience, you're in the DC area, is that correct? Maryland, DC? Yeah. So from what I understand from your experience, like, there's not people on every sidewalk selling significant shares into an ASC. Maybe just talk about where you're at in your career, your interest level in ambulatory surgery centers, what the climate's like in your region, what some of the challenges been, and just kind of walk us through sort of the other side of this as a young ophthalmologist who's trying to, or who would like to build or to buy in, but it's not as available where you are.
Thank you. Thanks for inviting me to come on the podcast also. I think, the young ophthalmologist experience of joining practices is probably a little different from how senior ophthalmologists see the process unfolding. And a lot of that has to do with, really, really high rates of turnover in the first 2-3 practices that we happen to join, and the culture that that high expected turnover creates. So there is sort of a expectation that the young ophthalmologist is going to join, stay there for a couple of years, and then move on to some other practice around the time that partnership discussions start. And I don't know if that is intentional, or it's a little bit chicken and the egg of, is that something that practices intentionally do to keep churning through associates rather than offering partnership, or if associates perceive that that's what's happening and therefore start looking for other opportunities. But regardless of how we got there, that is the reality that most of us experience in our first, second, or third jobs. And so, I graduated in 2019 from fellowship. So amongst my age cohort, which goes 2 years forward, 2 years back, those are the people that I keep in touch with. As I said on the RSA, I really only know 3 people my age who successfully bought into a practice at all, and I only know 2 who have bought into an ASC, and they're in very, very rural locations. I know absolutely 0 young ophthalmologists who have been able to successfully buy into an ASC in any kind of a metropolitan area. And that dichotomy of, maybe 200, 300 young ophthalmologists, and, the ASC buying rate is less than 1%. That's collectively known amongst us. And so that's led to this sort of notion, I don't know how conscious it is, but this notion that it's never going to happen, and it's not going to be offered, and therefore, it's not something that we expect or plan for. And again, going back to the chicken and egg thing of, do senior ophthalmologists feel that attitude and not offer partnership, or do young ophthalmologists not even pursue that? How did this state of affairs come to be? I'm not sure, but that's the reality. And I think that's really on many levels tragic, because it kind of goes back to a little fund of knowledge issue, where at baseline, when you're talking about buying into ASCs and valuations and private equity multiples, there's a baseline assumption that private equity can pay a very high multiple and young ophthalmologists can't. I thought about that fundamental assumption and questioned if that's correct. So they say precedence is providence. So I started looking at other specialties where private equity has been in place for a long time. And, the one I came across where private equity has been around the longest is dentistry. So recently I've started going to dental conferences. And wouldn't you know it, if you look at the average dental conference, half of the scheduled talks are about starting your own practice and practice financing and all of that. So when I started attending these dental conferences, I realized, I came into contact with a lot of bankers, Bank of America, Chase, people that are never at AAO. And after talking to them, I realized that in reality, young ophthalmologists seeking a buy-in into an ASC have access to greater financial resources than even private equity groups via these banks, where banks will look at the cash flow of the ASC, identify that it's a profitable business, and that you, as a principal trying to buy into this ASC, are going to inject new life and have a 30-year career in an already profitable business, and they will help you finance at very reasonable interest rates and at very good loan terms, even a 5x, 6x multiple quite easily and quite happily. And in fact, this is done quite routinely in the dental industry. So the financial system is very much structured to support young physicians buying into mature practices. But as a fund of knowledge issue, that's not really known. And I think that simple lack of knowledge has on the part of senior ophthalmologists and young ophthalmologists has really, first of all, allowed private equity to access ASC ownership unfettered, but also it's sort of hampered the relationship between the generations.
Jeff, can you respond to that?
I do think that there are, and maybe it's a misconception, but we've seen it in our practice too, as we're always looking for new physicians, and we'll find, recent residency graduates, more so than fellowship graduates, by the way, that said, like a salary, I'd like a bonus structure, but I'm not interested in a buy-in, or they don't even have a conception that they can buy in. And that's the way they want to work. Now, to say that that's everybody out there because you hear it a number of times, well, obviously that's just hearing what I'm hearing. That's got to be false. But, I think you need to have that discussion with people that you're interviewing and saying, and by the way, if for some reason, hey, you have so many people using your surgery center and it isn't practical to sell more shares, that's one thing. It's fully mature that way. But if it's not, I think then part of your discussion needs to be, even with the doc that comes in and say, I'm just interested in salary, bonus structure, and travel, and nothing to be ashamed of. There's some people that's their priority, and they can do very well that way. But we need to ask and say, if we find that you're, a good surgeon and you're growing practice, et cetera, we can find a way to and help you finance a way into becoming getting a partnership within the ASC. I think that is not just smart, but creative. And I don't think you have to go to a dental conference to figure out financing. But that's me. I'm very mature in my practice. For you, you had to find it out in different ways. My daughter's an orthodontist, so she's told me some of what you're telling me. And their cost structures are different than ours, but still multiples and things are very similar. But it still really comes down to, older docs there that are just holding on to the reins forever. What's your end game? I just don't think, if we want have a good future in this wonderful specialty of ophthalmology, we need to share somewhat. We don't have to give it all away. We're not giving it away for free, but we need to share and grow our practices. We're probably going to do 7,000 cases in our surgery center, four-room surgery center this year. I couldn't have done that, I don't think, without surgery, good surgeons who are partners that want to continue to grow this so they can do better as well.
Yeah. So John, it's one of these things where, Jeff's right. Cause I've spoken with other, senior owners who've said, man, I've tried to sell shares to my junior partners. They don't want it because they do have to pay for it. And at a 4x multiple, surgeon to surgeon market, that's fair market value, surgeon to surgeon, 3 to 4x of EBITDA. They don't want to go to the bank and ask for, $2 million. They're very happy making their $300,000, $400,000, $500,000, $600,000 a year, whatever it is. They have a great life. They don't want the risk, and that's cool. So it's more about identifying those docs like Dr. Singh, who want to buy in. Do you ever get calls from young doctors who are having these issues with their senior partner and saying, hey man, can you call and talk to this guy because it's not going through Bill? Do either you or John? I mean, is it a common thing that you get where you have to almost kind of intervene and help with that transition?
Yeah, we quite often we do that. We basically work both sides of it and work with the selling physician, the senior physician, and the new doc. I put financing together, as Dr. Singh said, and Dr. Whitman. I mean, there's a lot of places out there that now finally understand the value of a surgery center, and they understand how secure they are and what a great investment it is. So I basically would work with the new physician, put them in touch with financial groups, and the new surgeon never even have to leave, his or her desk. They get everything done over the internet and just over email. And as Dr. Singh said, very good rates. No guarantees and anything like that. And so a lot of times we would put that together and kind of broker those deals. But you're right, you do need to have some physicians you come across, they're just not interested. And it's hard to understand if they're 35 years old and they have a chance to make a 30% return on their investment, pay back their loans, build an asset for their personal financial statement that they can sell 20 years down the road, control their own destiny. And so we talked through all those things and we showed them, pro formas, but every now and then you'll find docs that are just not that interested. The good news is they're probably not going to leave your surgery center or practice because they're happy what they're doing. But we want doctors like Dr. Singh that really is interested in growing the practice, growing the surgery center and things like that. But,
well, I want to compliment JR for this because you know something, and a lot of people don't. And I've had two fellowship trained docs that have been in practice for a little over a year with a senior doc that have come to me and said, this guy's crazy. He tells me that if I buy into the surgery center, I have to pay a multiple. And he's actually and these guys have talked to friends who said, I've never heard of that. Well, there is some ignorance out there opposite of JR who knows his stuff. And that really truly don't know how this is done. And that's why it's great if you're serious about doing this, getting with the consultant. And no one asked me to do a commercial for the guys here, but for getting with the consultant and making sure you're treated fairly, but also, and I understand you don't necessarily always want to believe what the seller's selling you, and getting an independent idea there. Listening to a podcast like this is great. But if you're going to do something formal and you're going to spend a lot of your money, sometimes working with a consultant, dollars well spent.
Bill, they call you up and they say, hey, listen, I'm having this issue. The senior partner won't sell. Take us inside that conversation. What's the mindset of that senior surgeon? It's like, hey, I built this restaurant. I get that the food's good in my restaurant. You're the sous chef in my restaurant. You should be happy. People are coming and you're busy because of me. This is my place. I built it for you. So I get that mindset because I went through that in my own situation with my own dad. But maybe just kind of walk us through the psychology, because I'm sure that you have to sort of run these transitions. And I want people who are listening to this, who are in JR's situation, his mindset with this, what tools can your firm help them with? How can you reach a resolution where everybody can win?
First of all, I think one of the things that we don't do a very good job of in ophthalmology is really training on some of these business issues. I think there's a whole opportunity out there to help young ophthalmologists really understand the business of ophthalmology. And I think that's part of what we're talking about tonight is really not understanding, there's a multiple on it. It's a big number. It's scary. Many of these folks are coming out of school with debt. And they're trying to raise a family and buy a home and settle in. There's a lot of moving parts to their life. And so as a result of that, this opportunity may not be on the forefront. I think it should be on the forefront. And when I do get calls from young ophthalmologists to say, hey, I'm in this practice, I'm trying to talk my senior partner into selling it. I think it's a matter of sitting down and saying, okay, how do we, as Jeff talked about earlier, and Blake, is your dad did, how do I share this, and how do I grow back to growing this pie, and making sure that the older ophthalmologist, if you sell that surgery center to a PE firm, most likely that PE firm is going to say, hey, we want you to stick around for X number of years. So it's not like you're going to get a big check today and walk out the door tomorrow, right? You're going to hang around and you're going to generate that PE firm money to pay back the investment that they've made. Why would you? And it's nice and it's fun to run these numbers when young ophthalmologists call to say to the doctor, well, if that's what your thinking is, let me show you. If your young partner generates the revenue, brings the cases in, and the revenue continues to increase, look what you're going to get over a period of time, along with your ability to maintain your legacy, your lifestyle, and manage the center the way that you want it. And I think that's many times the issue is, I developed, this is my baby. I don't want to give it up. I don't want to give control up. And our job is then to convince them, you're not going to give up control. You're not going to lose money in this deal. You're actually going to make, in many cases, make more money in this with this opportunity to allow this younger ophthalmologist to buy into your practice, and you're going to be able to take care of the patients in your community.
So Bill, it's almost like instead of taking a big bag now, maybe let us buy in over time, we'll pay you for it, and you reduce your ownership, but even you can even stay on as a whatever, 10, 15, 20% owner, even years later, when you're not doing as much surgery, maybe you're doing gags and things like that. That's not ideal. But for someone who you're having a hard time, who doesn't want to sell completely, almost go into that emeritus ownership level and still having a chunk and still having, a paycheck, seems like that might be another route that you could take. Instead of taking it all up front, continue to have it, over time, just reduce your ownership to a smaller number. Is that what you're suggesting as an opportunity? Because that's what we're thinking of doing.
I think you're exactly right, and not to get off of this topic, but it also gives that older ophthalmologist a way to retire over a period of time. I think I don't see quite as many ophthalmologists coming in, seeing 60 patients on their last day, walking out the door, not coming back again. I see more ophthalmologists trying to figure out, as John Corboy taught us many, many years ago, how do I retire one day at a time? And I retire to something rather than from something. So I think this allows an ophthalmologist to, again, retire over a period of time, enjoying what he or she has built.
I think the financial literacy or lack thereof hurts both parties. I think, especially for senior ophthalmologists who have very large and very valuable ASCs, that financial literacy or not knowing that young ophthalmologists that they would consider offering a buy-in to will definitely be able to access financing. Not knowing that or not realizing that leads them in many cases to not even discuss it and sort of hide their retirement plans from their younger partners. So in my first practice, the ASC was valued at probably $30 million, maybe more. They did 12,000. We did 12,000 cases a year. So it was a very large and very profitable ASC. So when they were thinking about their exit plans, they didn't even discuss any of that with the associates. They just immediately went to talk to private equity. And when we came back to them later and said, why wouldn't you at least discuss this with us? Their number one reasoning was not like, we hate you or we think you're terrible people or anything like that. Their simple explanation was there's no way you can get access to this kind of financing. And that was factually inaccurate. We could have very easily, and of course I left that conversation, drove directly to my bank and said, can I get access to this kind of financing? And my banker said, yes, absolutely. Let's have a talk or let's have a discussion about this. No, you're not going to need to put up a personal guarantee. No, we don't care, what kind of educational debt you have, because that's considered separately. Yes, we're just looking at the cash flow of business. So, I could have come back and matched or actually even exceeded the private equity offer, because my ROI time horizon is so much longer than the private equity group, which dissolves in 7 to 10 years. So they need to have a much more aggressive ROI timeline. Therefore, that limits the multiple that they can offer the ASC owner. My career is 30 years plus. So I could have actually offered them more, but they didn't ask me. And so that hurt them. And then on the flip side, for young ophthalmologists, the lack of financial literacy also hurts us, because, we look at a 5 or 6x multiple, which might, as Dr. Strange said, be $4 million or $5 million for a big ASC. And, we think like that's scary, but in reality, it shouldn't be. It should be exciting because, you're buying into a very, very stable income stream, but we don't sort of realize that. And, I know many young ophthalmologists who are making a great living, our associates said no or did not want to consider buying into an ASC, but have a mortgage on a house for $1.5 million. And that internal inconsistency just doesn't, they don't think about that. So I think improving financial literacy and helping people understand how much greater access to capital they have than cash in their pocket, and how those two things are totally different. I think that's an important educational goal that would really help everybody.
Yeah, and I'm sitting here thinking like, we shouldn't have to pay PE rates. God damn it! Excuse my French, but I'm like, dude, like we shouldn't have to. But I say that, and I have a good buddy down south here. I won't say where because everybody would know, but he bought into his family's practice at 7x EBITDA, which is it's getting to, that's around PE-ish. You can get higher than that, but, and he did that because his dad said, you know what, I'm doing this for your own good, son, because if other your colleagues want to buy in, you can sell them 7x, and you could say, listen, I'm the son and I had to pay 7x. And so he kind of did that on purpose. But he knew with that practice that he would pay that back and he would still have a good income stream. I thought that was a big kick in the what, but it's true,
Well, if we can talk numbers for a second, Dr. Williamson, like you said, physician to physician sales, the 3 to 4x multiple is considered totally fair and normal, and I agree with you. For private equity, it's somewhere between 7 and 10x. So between 4 and 7 is 5 and 6, right? So potentially, especially practice owners who are looking for a faster exit can and should think about coming to the young ophthalmologist and saying, listen, I can get 7 to 10x, but then I have to stay in this practice and continue working as an employee, which I've never done in my life for the last 30 years. And I know that my last few years in practice are really going to stink because now I'm working for somebody else. So that's what 7 to 10x is going to get me. And you're expecting to pay 4x. Why don't you absorb a little bit of pain? I'll take a little bit of a hit. We'll meet at 5, 6x. You buy me out completely. I'm able to retire on a much faster timescale. And you're able to get ownership. That can be a win-win situation because, unlike the private equity group that needs the founding or the selling partner to stay in the practice so that they can recoup value, the young ophthalmologist actually needs and would likely benefit from having that partner sell and then depart so that they can sort of start molding the practice into their own vision faster. So, in that 5 to 6x space, which for some reason nobody ever talks about, there is a possibility for there to be a significant win-win situation, especially for the senior who's selling, because at that stage in their career, time may be more valuable to them than money. And if I can give you more time to pursue your, retirement agenda, that may be more valuable to you than 1 or 2x multiple additional, for which you're trading 3-4 years of your life. Especially as people get older, they generally tend to think that time is more valuable than money. And so that's something that I think is not discussed very much when we're talking about practice valuations. And actually recently, one of my friends bought in, and she was arguing with her senior partner about maybe, I think it was like $100,000 or $200,000, and that was holding up the deal. And my point to her was, you're not going to be able to move on with your life and stop thinking about this and stop talking about this until you buy in. And your ROI time horizon is so long, why are you worried about the $200,000? Why aren't you worried about the year that you've spent or wasted arguing about this? And I think, she thought about it, and a couple months later, she called me and said, I totally agree with you. I overpaid for the practice a little bit. And, that hurt in the moment, but subsequently now I'm, the principal partner, and I've never looked back, and I've never woken up and thought to myself, why did I overpay for this practice somewhat? This was the best decision I ever made.
Bill, you want to respond to that?
Yeah, I agree with Dr. Singh, and you guys, I want to challenge you guys, check my math here and make sure my math is right. But if I pay a 3 multiple, I pay a 4 multiple, or if I pay a 5 multiple, I'm and the practice or the surgery center does what it did this year, I'm going to begin to get my cash immediately when I buy in, okay, to pay back my loan. And so I'm going to get somewhere between a 33, 25 to 20% return on my investment. Okay, if I do it over 3, 4, or 5 years. Tell me where I can go and get that kind of return on my investment on something that I can control in a industry where over the last, help me, Dr. Whitman, over the last 15 years or so, ambulatory surgical center rates have increased year over year.
Bill, can we, do criminal enterprises count? Because that's one opportunity would be.
Okay, well, good point, Dr. Williamson.
I'm starting to consider a life of crime, and when I retire. So I'm sorry. Go ahead.
No, but I was going to say Mike Romanski has certainly been very helpful, and again, why it's worth being a news member, because it really been focused on trying to keep the ASC rates going up, because we're taking a big hit this year and maybe a bigger hit next year in terms of rates overall from CMS for clinic charges. So far it has not hit the ASC. So ASC is, just as you're saying, is a great place to put your money, and it's worth going into debt when you have a timeline, like JR is saying, when you have a timeline that's longer, it's a no-brainer.
John, I want you to respond to something that JR sent to me once. So he said something along the lines of, we're talking about OBS, and I think OBS has a place in ophthalmology for CON states and cash pay practices that are just cash pay. I think it's a niche. It should probably remain a niche, and the ASC I think is the future. That's my bias. That's what I think is the right thing. But his point was like, man, if I can't buy into one, why wouldn't I just build up my caseload in an OBS? And then once I have enough cases to get the right volume, go ahead and build my own. If I'm not able to buy into an ASC, let me just build my own. Do you think that's a good strategy? I looked at that, and my bias was like, well, no, I don't want you to. I don't want the message to be everybody who wants to have an ASC has to build an OBS first. But I also see his point. I mean, what is he supposed to do? Can you respond to that?
Well, I do agree. Build your own. The question on the OBS, and I worked with Steve Shepard, Bill Rabourn, Jeff Whitman, for OOS on the economics of an OBS, and they've got their secret sauce. But I still don't know how you get paid. I don't know how you get paid in an OBS, even to build it short term. I think you're onto something though. Build a smaller ASC and get paid. And to JR's point earlier, there is financing available because financial institutions understand the value of and the profitability of an ASC. So I do think if you can't build it, if you can't buy into one, you build one. Now, if you're in a CON state and maybe you can get some contracts with payers, but I still think they're doing some funny things there, and I'm not comfortable with that right now. But I do think if you build your own ASC, build it smaller, somewhere where you can expand, the rates are great. And
you're going to do better in the long run. In the short run, you're going to do better.
So Jeff, you wouldn't recommend doing the OBS to get your volume? Maybe get your volume up a different way. Maybe build a practice and go to someone's ASC, build up your volume, but eventually just build your own. You don't have to build the surgery suite.
Yeah, once, and again, that's where consultants are very helpful, is when am I at the magic number? Because it does change over time, but you built up your practice, you're using somebody else's ASC, maybe you're using 2 or 3 ASCs if in your metropolitan area, make sure you have enough time to operate. you build up your caseload, and then you start building. I've had several friends do that. I know somebody that's opening out in El Paso right now, and got his caseload up, built a surgery center. And by the way, there are some people that run a phenomenal number of cases through a one ORASC.
You know, if I can say something in defense of OBS, I agree with some of the points about some fishy billing practices that some people are advocating for, and I don't think that approach to OBS is a good one by any means. But one thing that I realized in my studies, so to speak, is that office-based surgery is not new. Office-based surgery is actually very, very old. And the Quad ASF, which is the OBS accreditation body, is actually older than the Joint Commission. Office-based surgery was pioneered by plastic surgery. So again, going back to that concept of precedence is providence, I spent a lot of time outside of ophthalmology going to plastic surgery conferences and talking to all these folks and figuring out how they get reimbursed for their plastics procedures in an office-based surgery center. And then from there, I used some of those contacts to talk to insurance companies. And I said to them, on an individual basis, how do you feel about me doing eye surgery in an office? Do you think that we can talk about getting a better compensation, for the 66984 professional fee? And not once, and I've talked to Aetna and United Healthcare and all these other organizations, not once did somebody say to me, what are you talking about? Everybody said, oh yeah, okay, totally. Just like plastic surgery, no problem, let's talk about it. So without using, some of those questionable billing practices, just having that conversation with insurers, it turns out that you actually can get much higher compensation for just charging the professional fee, not getting a facility fee. That does make office-based surgery very financially viable. It doesn't offer you the same type of protection, income protection, ASCs offer. Therefore, it's not a replacement for the ASC, and it never will be. Additionally, there's entire patient populations that will never be a candidate for office-based surgery because they're too sick, they're too nervous, their cataracts are too dense. So there's no possible threat that office-based surgery offers to ASC now or ever in the future. However, from a financial standpoint, office-based surgery is very viable. And for a young ophthalmologist who's starting a practice and is not able to secure that ASC buy-in, the cost of starting an OBS is very, very low. The upside is very, very high. And then as you get your surgical volume up and you do get your certificate of need or do you get your finances together to build an OBS, to build an ASC, all you have to do is transfer all your OR equipment out of this room, which is, and OBS is just a room in your practice, into your ASC, and you're good to go. So in my opinion, the downsides are to OBS are negligible. And the upside in terms of being able to earn more faster and get to your ultimate goal of having an ASC sooner is very appetizing.
So we're going to wrap up here in these last couple minutes. Bill, I just want you to very quickly respond to that. This is not an OBS versus ASC podcast, but maybe just quickly respond to that. And I'm going to have Jeff Whitman kind of give us his final thoughts, and we'll kind of close it out.
Yeah, I think Dr. Singh brings up a lot of really good points to be considered. I also think that one thing that I've noticed with young ophthalmologists, they're much more interactive and much more willing to share. And one of the things that we've successfully done for our clients around the country is we've put people together, maybe from different practices, but within a community where they can come together and develop a surgery center with smaller numbers of surgical cases, where somebody has a couple hundred here and a couple hundred there and 300 here, and they come together to build a surgery center. I think that can be a very powerful tool, especially if your senior partner says, oh, I'm not going to sell you any of mine. Well, okay, then here's what we're going to do. And I'm going to do this with 4 or 5 of my young colleagues, because my take is younger ophthalmologists are much more willing to cooperate and share than some of the older ophthalmologists.
Jeff, take us home.
First of all, I think we shared some excellent thoughts today. I am a proponent, and I will, say this loudly to anyone that listens to the podcast, though. If you're an older owner of a surgery center, loosen the strings some and see the value of getting more partners in, because eventually it means more cases, more income for everyone. So don't be greedy with your ownership in an ASC. And as we can see, and it's been discussed today, that there are different pathways to get to ASC ownership. But by understanding financing, by understanding the growth of your clinical practice, your surgery practice, all this is doable over time. It just takes some open-minded negotiation. And again, I'm just going to go back to sometimes getting consultant involved can help you get through the rough patches to end up with that happy ending of ASC ownership.
Well, I hope that you, the listeners out there, have learned something today, many different perspectives, very valuable points of view, and a very fun discussion with people who I really appreciate spending their time with us tonight. Thank you very much for listening to this episode of Off the Grid.